Hi, my name is Brian Apavu. I am a neurologist and epileptologist with an interest in philosophy, the mind, and living the examined life. Today, I want to dive into the type of seizures that we see in patients with epilepsy, how they arise in the brain, and how they manifest in patients. Before we talk about how we characterize and differentiate different seizure types, we should talk about how we determine where the seizures come from in the brain. The brain is a complex organ and has a number of eloquent regions of neocortex. We know from brain stimulation studies from Wilder Penfield and others that there are very specific parts of the neocortex that are responsible for a variety of different motor movements, sensory phenomena, and autonomic phenomena. We also know from research regarding disorders of the consciousness that the ascending reticular activating system is necessary for maintaining arousal, vigilance, and the full experience of consciousness. And that any dysfunction of the reticular activating system, whether it be from abnormality in the brainstem, the thalamus, or the diffuse dysfunction of the cerebral cortices bilaterally, these can lead to alterations of consciousness or awareness. Seizures represent abnormal neural firing within the brain, manifesting with changes in symptoms someone might experience. Those experiential changes are a reflection of what parts of the brain are affected at the onset and during the propagation and spread of a seizure. If a seizure were, for example, to start in the occipital lobe, where you have your visual cortex, an individual may see things. And if that seizure originates somewhere in the occipitotemporal region or has some component of the insular region, they may see things with a sense of fear or emotion. A lot of mesial temporal seizures might have a sensation of epigastric pain, and we see that with stimulation within those regions. Patients whose seizures develop right over the motor cortex on the right side might end up having, as their first a manifestation of seizures, motor movements on the left part of their body. So where the seizure starts from will have something to do with what symptoms the patient experiences. How they spread over the brain also has to do with how that seizure sort of evolves in terms of the characterization. Now, there are seizures that cause cause impairment in consciousness and some that do not. And we think of those seizures that cause impaired consciousness or impaired awareness to be those that have some involvement of the reticular activating system, whether it be the both involvement and spread to both cerebral cortices severely and diffusely, or involvement of the bilateral thalami or parts of the brainstem with the reticular activating system, whether not necessarily in the onset, but at some point in the spread or at the onset. So that's where we think that the impairment of consciousness really sort of arises from when we think about seizures that are associated with an impairment of awareness and an impairment of consciousness. In 2017, the International League Against Epilepsy published their most recent international classification system regarding seizure types. It's 2025 right now, so if you're watching this video sometime in the future, these guidelines might be updated. The basic classification system allows for seizures to be first categorized by their onset. So there are focal onset seizures, and these are defined as originating within networks limited to one hemisphere. They may be discretely localized or widely distributed, but within a region. Generalized onset seizures are defined as originating at some point within and rapidly engaging bilaterally distributed brain networks. There are seizures that we initially think about where they may have an unknown onset and there may still be evidence of certain defining motor or non-motor characteristics. And sometimes we initially can't tell if a seizure is focal or generalized in onset, and we need to do further evaluations, further discussion with the family and the patient, further diagnostic tests to really get at that. And so that's with further information on those future seizures that reclassification can occur. But when we classify it, we allow ourselves to have that sort of unknown onset as a convenient placeholder for the ignorance that we have at that given time. With focal seizures, they are further characterized by a level of awareness. In previous classifications of seizure types, this was characterized by consciousness. But to be pragmatic, we In evaluating the outward manifestation of a patient rather than their subjective inner experience, awareness is operationally used and defined as knowledge of the self and environment. During a focal aware seizure, consciousness is thought to be preserved. Awareness specifically refers to the awareness during a seizure and not to awareness of whether a seizure has occurred. If awareness of the event is impaired at any portion during the seizure, then the seizure is classified as a focal seizure with impaired awareness. As a practical matter, a focal aware seizure implies the ability of the person having the seizure to later verify their retained awareness. The classification system that we have further allows us to classify focal seizures into focal motor seizures or non-motor seizures, or focal motor onset or non-focal motor onset. The non-focal motor onset can be those that are just sensory or autonomic and so forth. The seizure type focal to bilateral tonic-clonic is a special category because of its occurrence and importance, even though it is a reflection of a propagation pattern of seizure activity rather than a unique seizure type. The phrase focal to bilateral tonic-clonic replaces a term that we used in the past, which is a secondary generalized tonic-clonic seizure. But they mean the same thing, and they try to represent that you have a seizure that starts in a certain area. You may have focal motor activity or focal sensory activity or whatnot, but as that seizure spreads really in a wide distributed network throughout the entire brain, that's when you start to get that bilateral tonic-clonic activity, and this is something that we see now, and it represents that seizure propagation pattern. In the newest classification, bilateral is used for propagation patterns of seizures, and generalized is used for seizures of generalized onset. So generalized onset seizures are divided into motor and non-motor seizures. Levels of awareness is not used as a classifier for generalized seizures, since the majority, although not all of generalized seizures, are associated with impaired awareness. By definition, by definition of the generalized branch of classification, motor activity should be bilateral from the onset in a generalized motor seizure, like the generalized motor tonic-clonic, generalized tonic, and or generalized clonic activity. In activities where bilateral onset of motor activity is asymmetric, it can be difficult in practice to determine whether the seizure has a focal or generalized onset. Absence seizures are a form of generalized seizure without necessarily any large motor activity, and they present themselves with a sudden cessation of activity and awareness. Absence seizures tend to occur in younger patients, have more of a sudden start and termination, and they usually display less complex automatisms as compared to focal seizures with impaired awareness, although you can get things like lip smacking and eyelid myoclonia that are relatively common, especially in children. Now, EEG information may be really important for the classification of absence seizures. Focal epileptiform activity may be seen in focal seizures, and with absence seizures, you may see more generalized abnormalities on EEGs. For instance, a typical generalized tonic-clonic seizure might manifest what we call a 3 Hz spike in wave pattern. But there are also atypical absence seizures that don't necessarily follow that 3 Hz pattern. Seizures of unknown onset can be categorized as motor, including tonic-clonic, non-motor, or unclassified seizures. And the term unclassified comprises both of seizures with a pattern that do not fit into other categories, or seizures that present themselves with insufficient information at the time that you're evaluated to make a categorization. Now, the expanded classification of seizure types provides another layer of seizure names built on the framework of the basic classification system. A focal seizure can be classified as a focal aware seizure, which we used to call simple partial seizures, or a focal impaired, or seizures with focal seizures that are focal with impaired awareness, which corresponded with what we used to call in the 80s the complex partial seizure. Focal aware or impaired awareness seizures can optionally be classified by adding one of the motor or non-motor terms, reflecting the earliest prominent sign of symptoms other than awareness. Alternatively, the focal seizure name can omit the mention of awareness as being inapplicable or unknown, just based on what you know about the seizure. Focal motor seizures have onset behaviors that can include activity such as atonic activity or a loss of tone, a focal loss of tone, tonic activity, which would represent focal tonic stiffening, clonic activity, which could represent focal rhythmic jerking, myoclonic activity, which can represent irregular brief focal jerking, less of the rhythmicity that we might see in a clonic movement, or epileptic spasms, which can reflect focal flexion or extension of the arms and flexion of the trunk. The distinction between clonic and myoclonic can be sometimes arbitrary, but clonic implies a sustained, regularly spaced stereotypical jerk, whereas myoclonus is thought to be less regular and in briefer runs. Other less obvious focal motor behaviors can include hyperkinetic activity, pedaling or thrashing, which we sometimes often see in frontal lobe epilepsies, where there's a where there's frontal onset of seizures with subsequent propagation, and seizures with automatisms. An automatism is a more or less coordinated, purposeless, repetitive motor activity. A focal motor seizure with behavioral arrest involves a stoppage or cessation of movement and responsiveness. Because brief behavioral arrest at the start of many seizures is common and difficult to identify, focal behavioral arrest seizures should comprise of behavioral arrest as the predominant manifestation of most of the seizure, or the entire seizure. Focal autonomic seizures present with gastrointestinal symptoms, a sense of cold flushing or heat, piloerection or goosebumps, palpitation, sexual arousal, respiratory changes, or autonomic effects. Focal cognitive seizures can be identified when the patient reports or exhibits some sort of a deficit in language, thinking, or high-order cortical function during the seizures when the patient symptoms outweigh other manifestations of the seizure. There are situations like deja vu, hallucination, delusions, and forced thinking are examples of induced abnormal cognitive phenomena. A more correct term could be focal impaired cognition seizures, although that's really challenging to say. But impaired cognition may be assumed in these sort of seizures since the seizures never improve cognitive function. Focal emotional seizures present with emotional changes, including fear, anxiety, agitation, anger phenomena, and are subjective and must be recalled and reported by the patient or caregiver for you to be able to, for that characterization of a seizure type to be made. Emotional symptoms comprise of a subjective component, whereas affective signs may or may not be accompanied by subjective emotionality. Impairment of awareness for events during the seizure does not classify the seizure as focal cognitive seizure because impairment of awareness can apply to any focal seizure. A focal sensory seizure can produce certain types of abnormal sensations, abnormal smells, abnormal visual stimuli, auditory stimuli, cold, hot sensations, or some vestibular sensations like a feeling of dizziness. The classification of generalized onset seizures is similar to that which we previously described back in the 80s in the 1981 classification system, with the addition of a few new types. Awareness is usually impaired with generalized onset seizures, so level awareness is not used as a classifier for these type of seizures. The main subdivision is whether they are motor or non-motor, and we think of the non-motor being absent seizures when it's generalized. The terms motor and non-motor are present in order to allow characterization of generalized onset motor and non-motor seizures about which nothing else could be said. Tonic-Clonic remains the term that we use to replace grand mal seizure types. So people use the term grand mal seizures. They're really referring to what's called a generalized tonic-clonic seizure, although grand mal still remains fairly popular. People to say it's an old French say that will undoubtedly still exist for some time. And we think of with generalized tonic-clonic seizures, it's as the terms as the term sort of sounds out. There's first a tonic phase of activity, so you can have a tonic extension of the bilateral arms and extension of the legs, and then that progresses to a clonic activity with that rhythmic jerking on top of that sustained tonic activity. That's why we call it a tonic-clonic seizure. Because there's a new seizure type characterized by myoclonic movements preceding tonic stiffening and clonic activity, or the sustained rhythmic jerking movement, it's important to document the early movements of a tonic-clonic seizure as being tonic to call it a tonic-clonic seizure. And as I mentioned, the clonic phase of that tonic-clonic seizure is that irregular decreasing frequency of jerks over the course of the event. During a tonic-clonic seizure, awareness is lost before or contemporaneously with the stiffening and jerking movements. Some tonic-clonic seizures may invoke a nonspecific feeling or an impending seizure or a brief period of head or limb version, none of which actually invalidates that the seizure is a generalized onset, since biologic processes never exhibit perfect synchrony when we try to characterize these things. Generalized clonic seizures begin, progress, and end with sustained rhythmic jerking of the limbs on both sides and often involve the head, neck, face, and trunk. Generalized clonic seizures are much less common than tonic-clonic seizures and mostly occur in neonates who don't have, these babies that are under 1 month of age don't necessarily have the myelination to be able to develop the sustained tonic-clonic activity. Usually their seizures that are generalized may be tonic in nature or clonic in nature. And the clonic seizures should be, in babies, should be differentiated from more normal behavior, which can be jittering or shuddering attacks. Generalized tonic seizures manifest as bilateral arm stiffening, bilateral extremity stiffening or elevation, often with neck stiffening, which might represent the neck extending upward. The classification presumes that the tonic activity is not followed by clonic movements, otherwise it's tonic-clonic activity. The tonic activity can be sustained abnormal posture, either in extension or flexion, sometimes accompanied with tremors of the extremities. The tonic activity can be distinguished. It can be difficult to distinguish from dystonic activity. When we think about dystonia, it's classically characterized as a sustained contraction of both agonist and antagonist muscles that produce an athetoid or a twisting movement, which, when prolonged, can produce abnormal postures. So there is some difference between a tonic activity and dystonic activity. We would think of movement disorders, although it can be really, really hard to distinguish on video or by visualization. Generalized myoclonic seizures can occur in isolation or in conjunction with tonic or atonic activity. Myoclonus represents a difference from clonus in that it's briefer and not as regularly repetitive. Myoclonus as a symptom has possible epileptic and non-epileptic etiologies. There are myoclonic seizure, and there's also non-epileptic myoclonus, where some patients can have those jerks, but they're not actually seizing. It's actually fairly common for individuals to have brief myoclonic jerks during sleep. It's happened to me. It's happened to my wife. While you're in sleep, you may have a few myoclonic jerks, and a lot of parents notice that in young children, and they worry that it's a seizure. But if you can wake a child or an individual up and those jerks go away, they're usually that's just sleep myoclonus, which is not a seizure. I should mention on this video, this video is for medical education purposes only. It is not medical advice. If you have any questions about a condition that you have or that others have, please talk to a professional doctor on your own. I am a doctor, but this is not providing medical advice. This is just medical education. A myoclonic atonic seizure involves brief jerking of the limbs or trunks followed by a limb drop. These seizures, previously called myoclonic astatic seizures, are commonly seen in what we call Deuce syndrome, but they can also be encountered in other types of epilepsy syndromes such as Lennox-Gastaut syndrome. Atonic seizures are important to talk about. Atonic means without tone. When leg tone is lost during a generalized atonic seizure, or what people refer to as the drop attack, the patient will fall, sometimes forward onto their knees or face. Recovery for these usually happens within seconds, although because of that loss of tone and the inability of an individual when they fall to bear themselves or from the falls, many patients can have a very significant injury. If you fall on your head and you don't have the ability to extend your arm because you've lost all motor activity, you could really hurt yourself very badly. And these are some of the most dangerous seizures in terms of where injury can occur at the time of the seizure. And in contrast to tonic or tonic-clonic seizures, these seizures more typically propel the patient into a backward fall, sometimes forward fall. Epileptic spasms are previously referred to as infantile spasms, and the term infantile spasms remains suitable for epileptic spasms that occur at the infantile age. An epileptic spasm, though, can occur in non-infantile periods as well, and in adults. So we use that term to really be accurate in terms of our classification of the seizure type. An epileptic spasm presents itself with a sudden flexion, extension, or a mixture of extension and flexion, predominantly proximal and truncal in nature. So the proximal muscles, the shoulders, and hips and so forth. And they commonly occur in clusters, and like I mentioned, they're most often occur in infancy and is commonly associated with a condition, which I'll talk to at some other point, called West syndrome. Generalized non-motor seizure types comprise of several varieties of absence seizures. There is a distinction that remains with what we call, in the most recent guidelines, which refer to both typical and atypical absence, because the two types of absence seizures, typical or atypical, are usually associated with different EEG patterns, different epilepsy syndromes, therapies, and prognoses. Back in the 1981 classification system, it was based on analysis of video EEG recordings, and absence seizures are considered atypical when they're associated with changes in tone and are more pronounced than in typical absence seizures, or the onset of cessation, or where the absence of cessation is not so abrupt. So in typical absence seizures, you think there's an abrupt onset and offset. With atypical, it may not be so clear that where the onset and offset are. And with, like I mentioned, with the typical absence seizures, you think of the 3 Hz spike and wave pattern on EEG, and that pattern may be a little different in atypical absence seizures. A myoclonic absence seizure refers to an absence seizure with rhythmic 3 Hz per second myoclonic movements caused by ratcheting abduction of the upper limbs, leading to a progressive arm elevation and associated 3 Hz generalized spike and wave discharges seen on an EEG. The duration of these is typically 10 seconds to a minute. There may not necessarily be that much clear impaired consciousness or impaired awareness when they're observed. These often happen in developmentally delayed individuals. And myoclonic absence seizures occur in a variety of genetic conditions where there is intellectual disability. Eyelid myoclonia is a seizure type where there's myoclonic jerks of the eyelids and upper deviation of the eyes, often precipitated by closing of the eyes or by light. Eyelid myoclonia can be associated with absence seizures, but also can be motor seizures without a corresponding absence seizure to it, making them pretty difficult to categorize. They are in the most recent 2017 classification system as non-motor absence seizures, which could be counterintuitive because there's actual jerking of the eyes. But the myoclonia in this sense is meant to link it to absence seizures rather than with non-motor seizures, which can be focal. Absence seizures with eyelid myoclonia, seizures or EEG paroxysms induced by eyelid closure and photosensitivity, where you're shining light, constitute a triad of what we call Chivan syndrome. So I hope this video was helpful for you. It's one of a number that I want to create to help people understand epilepsy and how we think about how we diagnose it, treat it, and think about it. If you like this video, please click like to this video and subscribe to my channel, and we'll talk again soon. Have a great day.